Hey everybody, this is Mrs. Poindexter. This is going to be an overview of diabetes mellitus. So, like I said, this is going to be a review. We're just going to hit some of the highlights. So, what is diabetes? Remember, it's a chronic condition with two problems, hypoglycemia or the inappropriate metabolism of carbohydrates, fats, and proteins. There are two types. We have type 1, where there is an absolute absence of insulin. This is typically going to be related to an autoimmune issue, or type 2, where we talk about resistance to insulin and or decrease in insulin production. So remember, type 1, a lot of times this is an acute onset that a patient will experience symptoms, where type 2 is a little bit more of a insidious and takes a longer time for symptoms to appear. In type 2 diabetes, either there is going to be a decrease of insulin or cells become resistant to insulin. So there is like a synergistic effect, whereas insulin secretion decreases, it can lead to an increase to insulin resistance, or as insulin resistance increases, it can lead to a decrease in insulin secretion. So this just kind of gives you an idea of basically what happens at the cellular level. So here, this shows you normal insulin metabolism. You have your glucose. Insulin basically helps get it into the cell, where here we have some resistance. You can see the buildup of glucose in the bloodstream. You see insulin, but it's not being able to actually penetrate the cell to get inside. So comparison of characteristics. Remember, type 1 is destruction of the pancreatic beta cells. It's autoimmune. There is an absolute lack of insulin. A lot of times there is a strong hereditary link. Onset is abrupt. Peak onset 11 to 13 years. Type 2 is an insulin resistance and or insufficiency or deficiency of insulin. There is a decrease in the number and size of the pancreatic beta cells. Again, onset is insidious. There is a genetic predisposition and typically can occur when somebody is 4 years or older, but there are more cases of childhood diabetes that are not type 1. Clinical manifestations, common symptoms of diabetes overall, and like we talked in class, the 3 Ps, you'll see it a lot more predominant in your type 1s. But polyuria, polydipsia, and polyphagia. And you have to kind of think what's going on in the body in terms of what are causing these symptoms. So if somebody has too much sugar in their body, the body's response is try to get rid of that excess sugar, so it's going to make you thirsty and pee more. But also, if the cells have a sense that they're not getting the glucose they need, it's going to increase your hunger. So somebody who's hypoglycemic can have polyphagia, but also somebody who has extreme high blood sugars, and like say a type 1 where the sugar is not getting into the cell, then the body's going to give this response that, hey, you need to eat more. It's just kind of unknowing of what's floating around that bloodstream that the cells can't get access to. So the 3 Ps. Also some other clinical manifestations of diabetes, extreme fatigue, blurry vision, cuts and bruises that are slow to heal, weight loss, even though you're eating more, which is going to be more typical with your type 1s. And this has a lot to do with the increase in metabolism, tingling, pain, or numbness in hands or feet, which is neuropathy, which is seen typically more in type 2, but of course is something that can cross over to type 1. This is a good chart. It's showing you the negative feedback loop of hyperglycemia versus hypoglycemia. So take a few minutes, pause this, review it. If you have any questions, let me know. This right here is a good overview of what basically happens when there's no insulin in the body. So cells starve, triggers the polyphagia, hyperglycemia. Again, the body wants to get rid of that excess glucose, so it causes osmotic diuresis, which leads to polyuria, which leads to the glucosuria, but obviously polyuria can lead to dehydration, which leads to the sensation needing to drink as well. Diagnosing diabetes, make sure you're aware of what is needed to diagnose a person. Risk factors, even before we diagnose, we have to kind of know what to look for. What is the picture of a person with type 2 diabetes? So it's going to be the person who's obese, has hypertension, sedentary lifestyles, high cholesterol, cigarette smoking, genetics, first-degree relatives, mom, dad, sister, brother, in certain ethnic groups. And the way I have them listed are basically in order of highest incident to lowest, Native Americans and Alaskans, all the way to Caucasians, and also having history of gestational diabetes or delivering a baby over 9 pounds. So these are just risk factors for type 2 diabetes. What you'll also see with those with type 2 diabetes, a person may get diagnosed with what's called metabolic syndrome. So a person may have a couple of these components prior to being diagnosed with type 2 diabetes. In the work that I do, I see a lot of patients with the polycystic ovarian syndrome before they get a type 2 diabetes diagnosis, but having some combination of these different diagnoses kind of fall under this umbrella of metabolic syndrome. So diagnosing the diabetic, and what you need to notice, this is typically for a stable patient. So this is a patient who's probably coming to the clinic, so getting a random blood sugar of more than 200, must also have signs and symptoms of diabetes. A fasting plasma sugar or glucose greater than 126. The person needs to be at least NPO for 8 hours, or a 2-hour post-load glucose, which is basically having greater than 200 during an oral glucose tolerance test. The test must follow the WHO guidelines, and the 1 and 3 hour GTT is usually used to diagnose gestational diabetes. But the ones that you'll see, you won't usually see these 2-hour post-load glucose test. It will be more of the combination of random with symptoms or the fasting. And like I talked in class, just because if somebody comes in with one fasting of the greater than 126, a doctor isn't normally just going to say, yeah, you're diabetic. They may have that in combination with looking at an A1C, having the patient come back in 3 months, make some changes, and do another test. Further testing, the glycated hemoglobin, the HbA1c or A1C, looks at the average blood glucose levels over approximately 2 to 3 months. It indicates the average blood glucose level over 120 days, because remember we talked about the lifespan of a red blood cell. This over here, this is our red blood cell going like, oh no! And this right here is actually a glucose molecule. It will hitch a ride on the red blood cell. Ranges of 4 to 6% indicate good control of a non-diabetic. The goal for somebody who's diagnosed as a diabetic is less than 7%, and anything above 8% indicates poor diabetic control. Urine testing is not used to diagnose. What urine testing is used for, first one here, testing for ketones, is part of the sick day rules for diabetics who are type 1. Just because it is a waste product of fat metabolism. When we are sick, our metabolism tends to increase. It may indicate an impending ketoacidosis, and it's typically recommended during acute illness or even very stressful events. Testing for renal function. So positive proteinuria may indicate microvascular changes. Or another terminology is microalbuminuria, which can just kind of trigger some early changes of some damage going on in the kidneys from diabetes. Testing for glucose is not used, like I said, for diagnosing, and it typically does not accurately reflect the blood glucose levels at the time that the test is being done. So the kidneys are the site of where proteinuria happens. So in the podocytes, in the glomerulus, this is basically where the filtration happens. When there's damage here, basically protein cannot get filtered back into the body and it spills over into the urine. Chronic complications of diabetes. So we're about 10 minutes in. If you need a little break, go ahead and pause. If you're ready to keep on going, keep on going. So microvascular and microvascular, so big and little. So this kind of gives you a good side-by-side of all the different complications of macro versus micro. Your micro are going to affect the eyes, kidneys, and the nerves. Where macro, think big, think brain, heart, and the extremities. And you can take a few minutes to review this. And if you want, you can review Bill's story. If it gets going, there we go.
I'm Bill. I've had diabetes since I was a little kid, and I used to smoke. That's a bad combination, but if you're doing that, I've got a tip for you. Make a list. Put the people you love at the top. Put down your eyes, your legs, your kidneys, and your heart. Now, cross off all the things you're okay with losing because you rather smoke.
You can quit. For free help, visit cdc.gov/tips.
So again, you can see the importance of and the effects of diabetes has. So chronic health problems related to vascular changes may affect all the organs in the body. Chronic complications occur when tissues that are permeable to glucose are chronically exposed to hyperglycemia. So again, like I talked about, too much sugar equals glucose toxicity. So this is typically what happens. Basement membranes are thickened and there's organ damage, impaired function, cell impairment, and chronic ischemia and tissue hypoxia. So the macrovascular are going to be all major blood vessels, atherosclerosis, coronary artery disease, cerebrovascular disease, so embolic stroke is 3 times more likely, peripheral arterial disease is 4 times greater. Again, think heart, brain, extremities. So where does the problem start with the macro? It's going to be because of endothelial dysfunction. The role of the endothelial cells basically releases substances that control vascular relaxation and contraction, as well as enzymes that control blood clotting, immune function, and platelets adhesion. So when there is a problem with this, you'll see an increase in fibrogen, platelet aggregation, and small dense lipoproteins increase, which leads to atherosclerosis. So the microvascular disease is the leading cause of death in all patients with diabetes. Your microvascular complications, think teeny tiny small, so we're going to talk about eyes, the kidneys, and the nerves, so neuropathy, and it's going to be dysfunction of the nerves, nephropathy, make sure you read your words when you take your test. That's going to be talking about your kidneys, occurs in 24% of diabetic patients, is the leading cause of end-stage renal disease, ESRD, and retinopathy, basically with eyes, is the leading cause of new onset blindness in those ages 20 to 74 with diabetes. So think about when you're seeing these patients for the first time, what type of consults your clinic or the hospital may be making in terms of whatever problems are going on, or just knowing the complications that arise with diabetes. So when you're assessing your patients, kind of learn the terminology that goes along with the different neuropathies. So sensory talk about touch being unpleasant, numbness, tingling, the paresthesia. With motor, it affects basically the ability to kind of feel the feet. Also can affect the autonomic system and just affects organ systems and reduces their function overall. Other issues with the neuropathy, sometimes patients can have a relentless leg pain that is worse at night. And sometimes having undersensation, they can also have a problem of having increased sensitivity to stimuli. So back when we talked about pain, that some treatments are atypical, so not necessarily your run-of-the-mill pain medications that help with nerve pain and damage, which would be anticonvulsive, tricyclid antidepressives like amitriptyline or Elavil, SSRIs, capsaicin, a TENS unit, NSAIDs, and tramadol, or also as known as Ultram. So this just kind of a look again at the diabetic nephropathy. So typically the one on the left over here shows you a normal glomerular capillary, and basically here's the protein, and that it gets reabsorbed back into the body, where here you can see where there is damage, and that protein is actually leaking out and getting into the urine. So some of the tests that you will see physicians order are 24-hour urine collection or a random urine protein to creatinine ratio, or you might hear it called as the P to C. So with diabetic nephropathy, chronic hyperglycemia will cause damage to the vasculature of the kidneys and cause hypertension in the vessels of the kidneys, which will lead to that damage and allowing the protein to spill into the urine. So really the best treatment is prevention. So if you have patients, because remember the kidneys are also involved in regulating blood pressure overall, that using ACE inhibitors to help basically protect the kidneys. It can help slow the progression of renal disease. It can delay the onset of nephropathy. It doesn't affect blood sugar, and it will lower the glomerular filtration pressure, which basically slows down the development of renal injury, which is caused by hypertension in the vessels of the kidneys. Motor neuropathy, so if you have patients, you see some of these issues, you will know that it's possibly a direct link to diabetes if they have that diagnosis, so having hammer toe or claw toe. Autonomic neuropathies, you will see some patients with diabetes who may have gastroparesis, neurogenic bladder, loss of cardiac reflexes, defective counterregulation of glucose, hindrances, the inability to sweat, and also erectile dysfunction and ejaculatory changes in men. So again, when you're looking, say, at a patient's list of medications, you want to kind of get a sense of if what they're taking is in direct relationship to being a cause from the diabetes. So like gastroparesis, basically if things are not going through the system, are they taking any medications that kind of help increase motility? Peripheral neuropathy is something that as nurses we will tend to deal with more often, just because, like we talked in class, feet are so important and are just at a greater risk of injury, especially if patients don't take care of their feet. So it affects the distal portion of the nerves, especially of the lower extremities. Things that we become concerned with patient safety is the unsteady gait, the inability to feel pain or even temperature. And I think I used the example of the patient that walked across hot asphalt with bare feet and didn't feel it and ended up getting some severe burns that led to a septic infection. So again, treatments are going to be some of these atypical medications, and for the fact that you've seen it twice now in this PowerPoint would make me think that you should just be aware. Acute complications, so acute means quick onset. Hypoglycemia and hyperglycemia is what we're going to review. We're about 20 minutes in, so if you need a quick little break, go ahead and give this a pause. Okay, if not, and if you did, great. Welcome back. So acute complications. Talk about hypoglycemia. So this is going to be blood sugars less than 70 for both type 1 and 2. Usually symptoms are sudden onset. Causes either too much insulin or oral hypoglycemic agents, or too little food, or excessive physical activity. Make sure you know your symptoms: sweating, tremors, tachycardia, palpitations, anxiety and hunger, polyphagia. Depending on if it's moderate or severe, so kind of understand that the symptoms, if you kind of review them, are quite neurologic. And the best way that I kind of describe it as it's getting more severe is imagine somebody who's appears to be drunk. It can be a medical emergency just because the brain needs a constant supply of glucose. Just remember that the brain cannot make or store more than a few minutes of a supply. Treatments, make sure you know your treatment. Okay, so prevention is best. Patient education, allow for higher sugars in those that are prone to hypoglycemia, and frequent monitoring. So if you have a patient that's more prone to this and likes to work out, hey, tell them to eat a snack before they work out. It's better to be proactive than reactive. So if you have a patient whose blood sugar is less than 70 and they're walking and talking with you, load with 15 grams of a simple sugar. This list here kind of gives you some ideas. You're basically then, after you administer that, check in 15 minutes, repeat carbohydrate load until the blood sugar is over 70. Once you do have that, provide a snack of carb and protein within 30 to 60 minutes. If a patient is unconscious or is unable to swallow, we will give them glucagon. It is a hormone produced by the alpha cells of the pancreas that stimulate the liver to convert glycogen to glucose. So 1 milligram sub-Q or IM. You can also give a patient 25 to 50 mLs of 50% dextrose in water via IV push at a rate of 10 mLs per minute. So make sure you know how to treat hypoglycemia. Diabetic ketoacidosis. This is an emergency. A lot of type 1 diabetics are diagnosed with type 1 diabetes by getting a DKA diagnosis. This is caused by an absence or significant inadequate amount of insulin. So it will typically happen in type 1 diabetics or newly diagnosed type 2s, which is a little bit more rare. And typically those who have been previously diagnosed with an infection, trauma, increased stress, or non-compliance. Here are your symptoms: hyperglycemia of greater than 250, pH less than 7.35, positive for serum ketones, metabolic acidosis. Read the name, know the name. It will tell you everything you need to know. Diabetic, keto, ketones, acidosis. Looking for small respirations, rapid and deep. They have an acetone breath, which is kind of fruity. There's going to be metabolic changes. Look at all your signs and symptoms, and the ones that I have underlined are going to be a little bit more predominant. I had one type 1 that said they always knew they were going into DKA because they started vomiting and having abdominal pain. Okay. This just kind of gives you the rundown of how acidosis can happen. Pause it. Treatments for DKA. You want to give them IV fluids. Monitor to avoid cerebral edema. which will lead to possible hypovolemic shock, normal saline to replace lost fluids, and also potassium replacement. Give them insulin, and of course, treat the underlying problem if there is a different cause. So what's going to happen and why potassium monitoring needs to happen? So before treatment, you're going to see there's going to be a do-si-do where some of the hydrogen molecules are going to trade places with some of the potassium, and it will go into the bloodstream, and so potassium levels will increase. During treatment, insulin will help pull glucose and potassium back into the cells. So that's why it's important to see how high the elevation is, but while you're treating, it can also drop it. So you may also need to address that issue during treatment. It's a fine balance. Another issue, which is going to be a little bit more predominant in your elderly population and type 2 diabetics, this will not ever happen in a type 1 diabetic, which is the hyperglycemic hyperosmolar non-ketotic syndrome, HHNS, or you'll sometimes see it written out as HONK. Okay, it's a serious life-threatening condition where there will be hyperosmolarity and hyperglycemia. So again, just read the name, know what the name says. Hyperglycemia, hyperosmolar, non-ketotic, no ketones, okay? And look how high the blood sugar can get. Usually will occur in elderly with no known history of diabetes, usually related to infection, other stressors, surgeries, or dialysis. A lot of times these patients have poor fluid intake. Symptoms: hypertension, profound dehydration, very, very dehydrated. Because just think about it, look what's going on here. This totally, just reading this makes me dehydrated. May also have a coexisting cardiac and renal disease. Very high glucose levels. Can I say that it's high? And also a high serum osmolarity. And again, serum osmolarity talks about looking at solutes in the blood. Electrolyte and bun levels are consistent with dehydration. So, what is the difference between HHNS and DKA? HHNS, lax. Make sure you know what's in red here. Lax acidosis, serum or urine ketones, and no abdominal pain. Why? Because insulin levels produced are so low and are too low to prevent hyperglycemia resulting in osmotic diuresis, but high enough to prevent fat breakdown, so that's why there's no ketones. Whereas in DKA, no insulin is present and promotes the breakdown of stored glucose, protein, and fat, hence why we get the ketones. The patient population is primarily elderly. It has no history of type of diabetes or type 2. Shock or coma is brought on by the dehydration, where DKA is brought on by the metabolic acidosis. So HHNS dehydration is going to be a big problem. So how are we going to treat this? Main goal: rehydration, because I talked about dehydration, a lot of dehydration. Why? Because the patient population is also typically older and may have an underlying condition, and that they're sensitive to fluid overload, heart failure, and cardiac dysrhythmia. So we can't push fluids fast on these patients. We need to correct any electrolyte imbalances, insulin to treat the hyperglycemia, which, oh my gosh, is through the roof. Treat the underlying medical condition, and again, education and frequent blood sticks to prevent reoccurrence. So, education for patients with diabetes. As nurses, you need to educate patients about foot care, sick day rules, who is at risk, especially if you're talking to a patient. Maybe trying to get them to understand their risk and of those they love, and medication interactions with diabetes like steroids that would result in the need in increased monitoring of glucose levels. Foot care, make sure you know all these, all of them. It's like 2 slides worth, so that's quite a bit, but make sure you know all of them. Sick day rules. This is going to be mainly for your type 1 diabetics, type 1. Monitor blood sugars. Continue to take insulin even if you don't feel like eating. Got to continue to start taking your medicine, and we've talked a little bit about that in class, but this is where critical thinking comes into play. So if they are taking basal insulin, which is kind of the background insulin, they need to keep taking that, but obviously they wouldn't take meal insulin if they're not actually eating. Okay. Increase fluids to prevent dehydration. Maintain nutritional needs through soft foods and liquids. Test the urine for ketones for your type 1s. Rest. Know the parameters of when to call a provider. A blood sugar is greater than 240, a fever greater than 101.5 that doesn't respond to Tylenol for more than 24 hours, or if things are kind of changing, vomiting increases, diarrhea increases, just because we don't want things to go in a couple different directions with the patient, whether DKA or HHNS. This is a really good example just to show you what happens to stress and illness to a diabetic patient. This was an actual patient of mine who was a type 1. And you can kind of see here the 3 days when they were diagnosed for strep throat and starting an antibiotic. And then you can see how things improve after that. Steroids and hyperglycemia. So what happens, it increases the cortisol levels in the body, which stimulate the glyconeogenesis in the liver and inhibits insulin production, which leads to elevated blood sugar levels. So patients with diabetes need to monitor more often and to basically compensate through medication to manage their blood sugars. Lifestyle changes for clients with diabetes. So we need to be able to talk to patients about nutrition and exercise. So when it comes to nutrition, we're going to talk about proteins, carbs, and fats. Notice that there needs to be a good balance. Fiber is good. They can still drink alcohol, but not too much because it will increase the risk for DKA. Sweeteners are okay in moderation, and watch misleading food labels. Exercise therapy is essential. Look at this beautiful cloud. So basically consistent exercise, same time each day, same amount, same intensity. Our bodies love a schedule, love predictability. Risk, if your patient's at risk for post-exercise hypoglycemia, educate patients about pre-exercise snack. Pre meaning before they exercise. Insulin and diabetes, administrating the devices and side effects. Usually given sub-Q. So when we look at insulin, only NPH needs to be agitated, rolled in the palms. Others should be clear. If it is cloudy or has crystals in it, it should be discarded. Rubber cap needs to be cleaned, and the skin should be prepped with alcohol or soap. Know your onsets, peaks, durations, and uses, and the different types of insulins. This is a great chart, print it up, love it, learn it. Different injection sites. Fastest is going to be the abdomen, then the arms, then the thighs, and then the booty is last. And here it is again. The devices, when we talk about syringes, make sure you know how to read your syringes, know the sizes. I'm sure needles for those with less adipose tissue or fat tissue. And you can see what happens, how quickly a needle can dull after it's been used. Injection devices, insulin pens are preloaded, they're easy dial up, they usually have 300 units. So easy to use. In terms of insulin pumps for type 1s, know your information here in red. And just make sure that you understand some of the problems that pumps, of malfunctions of pumps can have, but make sure you know your things here in red. And just here's some instructions about how a pump looks and where it goes into the body. Insulin therapy side effects, local reactions, systemic is kind of rare. You want to administer insulin at room temperature to cut down on issues like the lipoatrophy or the lipohypertrophy. So just make sure you know the difference between the two. One is loss of fat and one where you see like a fatty mass. So some different insulin therapy side effects: insulin waning versus the dawn effect and the Smolgy effect. Just take some time to read these over. If you do have any questions for me on any of this, don't hesitate to ask. There's a lot of great resources out there that I have provided for you. But if you don't have any questions, I hope this quick overview was just a good refresher of what you need to focus on. That's it.